Welcome to Nourish MD, Doctor-Dietitian Dialogues, where doctors and dietitians empower you about your health and discuss and provide a better path to health and wellness. Proudly presented by Concierge Medical Practice Private Physicians Medical Associates, PPMA, with your hosts, registered dietitians and nutritionist, Lauren Papanos and Romana Brennan.
All right, everyone, welcome to Nourish MDs. I'm your host, Lauren Papanos. Today, Romana couldn't be with us, but we're going to have an awesome episode. I've got a really great guest for us today, and that is Dr. Seth Cohen. He is a urologist over at City of Hope, and we're going to be talking about some of the work that he does more in the urology space and also pelvic floor reconstruction as well. And so I'm really excited to get into our conversation and to just present to you a little bit more information about both of these really important subjects. So Dr. Cohen, thank you so much for being here and welcome.
Oh, it's really my pleasure, Lauren. Thanks so much to you and to the PPMA team. It's really just an honor to be a part of this effort. So and deliver more information to patients that we hope benefit from it. So as Lauren said, my name is Seth Cohen. It's nice to meet everybody in podcast land. My background is I'm a urologist. What is a urologist? A urologist is a physician that specializes in the genitourinary tract. That's a bit of a fancy way of saying the kidneys down through the bladder and the pelvic floor. And there are certainly some more details within that, but that's kind of a brief overview. I did my residency at UC San Diego, and then subsequently did a fellowship in female pelvic medicine and reconstructive surgery that is otherwise known as urogynecology, otherwise known as female urology. So a few different monikers for that. But essentially, it is a subset of urologists that will actually focus particularly on women suffering with pelvic floor disorders. And there's a myriad of those we can talk about. So I did specialty training in that at UCLA for a couple of years, and then was fortunate enough to join the City of Hope team, which City of Hope is an interesting institution. It has a large profile in cancer care, but certainly it has outreach into other various specialties, including a very wide array of urology care. And I was brought on to help provide my specialty to patients that need it within the City of Hope ecosystem. A number of those patients have gone through cancer care and are survivorship patients. A number of those patients have never had cancer, and they're just seeking a particularly high level of effort and knowledge in things that they're suffering with. And so that's my day-to-day is wonderful. I get to help people on the whole. It is a mix of medicine and surgery. So on any given week, a couple of days are spent in the operating room and several days are spent in the clinic treating patients on a face-to-face basis. And I really get to enjoy all aspects of medical care. And that's one of the reasons I went into this particular specialty.
Amazing. So awesome. And such a really niche specialty that you have as well. And I'd love to just know, when you were in med school, like what gathered your interest or piqued your interest in this specific field?
Yeah, it's a great question. Initially when I was going through med school, I was going to be an orthopedic surgeon. Bones and hammers, sports, was something I grew up kind of interested in. As a side note, my initial interest in medicine developed when I was in high school, and I grew up in Orange County. So go Orange County. And I was a volunteer at St. Joseph's Hospital in Orange, California, and had the candy striper outfit with the red striped shirt and everything, and really just developed a passion for helping people and for medical care. Ultimately, in med school, I thought I was going to be an orthopedic surgeon. And during our third year of med school, we do rotations in various surgical subspecialties. And I got urology on a whim. It wasn't my first choice, but that was the one I got swept up into and was super impressed with it. Just as I kind of alluded to, a very diverse surgical subspecialty, traditionally very engaged with new technology. We do a lot of robotic surgery. There's a very wide mix of procedures, from office-based procedures through very, very extensive, very long, comprehensive operating room procedures. And then also a very wide breadth of patient care, from men through women and actually even pediatric urology. And ultimately, my particular subspecialty I became interested in as a resident, working with patients suffering with pelvic floor disorders, including neurogenic challenges like Parkinson's and spinal cord injuries. And what I became really enamored with was the thought of developing a reconstructive plan to improve someone's quality of life and those suffering with urinary incontinence and pelvic floor challenges. And that's a pretty wide way of a pretty long way of saying I like to put things back together. And when I see someone suffering, my goal is to figure out what we can do to medicinally put them back together, behaviorally put them back together potentially, or in many instances, surgically put them back together. And so for me, it's an opportunity to work with my mind and my hands to really give form and function to disease processes that otherwise would really significantly limit someone's ability to live their day to day.
Oh, yeah, it's really important. And I know that it touches many people that are struggling with these issues. And, I think that for our patients that they're going to want to know a little bit more of some of the broad things of urology, right? And then I want to definitely get into some of the more pelvic floor specific things too, because I think that that's a really important conversation for us to have. Maybe you can just start off and tell me, what would you say if you had to pick like the most top 5 most common urological issues, diseases that you're seeing amongst patients every day?
Sure. No, absolutely. One of the things that people come into the office really suffering with is urinary urgency and frequency, or a sense of living their lives in the bathroom and having to pee very, very commonly. And it's, gosh, Dr. Cohen, I feel like I'm just every 15 to 20 minutes, I feel like I'm having to go to the bathroom. And perhaps that's associated with leakage, and they're leaking on themselves as well. And they're wearing pads in their undergarment, or they're even worse, they're wearing diapers. And very significant quality of life issue. And there's a lot of ways we can try and help with that. But I think what I really try to ask patients to discern are, what is the type of incontinence they're experiencing? And it's not always easy to parse that out. But the 2 main types of incontinence people will experience, one is called stress urinary incontinence, and one is called urgency urinary incontinence. And stress urinary incontinence really goes back to the urethra. What is the urethra? It's the tube that empties your bladder into the outside world. And in women, it's only about 4 to 5 centimeters in length. In men, it's about 20 to 25 centimeters in length. And so generally speaking, when someone's suffering your stress urinary incontinence, and this is really women much more commonly than men. Men have some very unique situations where that would occur. What we describe as the urethra has a hammock of ligaments that live under it. And as someone matures and ages and changes and experiences various life events, that hammock of ligaments that live underneath the urethra atrophies and weakens over time. And so the urethra gapes open when you cough, sneeze, laugh, move, jump, lift groceries, lift a child, lift a grandchild. And so instead of having that ligamentous hammock support underneath it to buttress it and keep it coapted, the urethra gapes open when you create pressure or valsalva, when you're lifting or coughing or sneezing, and urine comes out from the urethra in an unplanned, unwarranted manner. And that's stress urinary incontinence. Urgency urinary incontinence, that is a little different. So we talked about the urethra. The urethra empties the bladder. The bladder is a reservoir. It's a hollow muscle. It got nerves and muscle fibers, and it's really quite an ingenious organ. And what it does is it stores urine at low pressures, and it empties urine at low pressures in a perfect world. Now, generally, we want that to be volitional, meaning you plan out when that happens. You start to get a sense that your bladder's getting full, you're having an urgency sensation, and then in a planned, coordinated fashion, you go to the bathroom and you pee and empty your bladder and you walk away, and hopefully you don't have to come back for a few hours. Now, that's not the case for a lot of people. And so when someone develops urgency urinary incontinence, what may be occurring is that bladder muscle may be spasming and literally contracting without their permission at unwanted times and expelling urine into the outside world. So for instance, someone may describe that, every time I'm driving up to my garage door, I start to see that garage door open and I just get that urge and I got to run to the bathroom right when I get in the door. Or perhaps they start to take their keys out to open their home door and they start to get the urge to go to the bathroom. Or perhaps they feel like when they're at work, they're getting their urgency a lot to go to the bathroom. And there's, once again, lots of reasons this can happen, but ultimately it's a sensation or need to go more often than you want, and perhaps associated with a leakage event. And we try to parse out which one is causing more suffering, perhaps a combination of both. And there's certainly treatment pathways we can walk down when we're trying to counsel someone about how to really ameliorate that or lessen that bother in their life.
And is this happening for both men and women equally, or would you say that women suffer more than men do, or vice versa?
Certainly men suffer with this as well. Their challenges are a little different. Generally, men are going to have more challenges associated with the presence of a prostate. And so a lot of voiding dysfunction for a large portion of men may revolve around a slow urinary stream or weak urinary stream or a difficulty emptying as a prostate enlarges as they get older. Women will have more experience with stress incontinence, largely because that is associated with vaginal delivery. And it's one of the challenges that occur in the setting of vaginal deliveries is really, that's a pretty traumatic process for the pelvic floor. And so as women age and mature, they're going to experience more stress urinary incontinence than men will. Men will rarely have stress incontinence. If they had that, it will likely be in the setting of an operation like a prostatectomy. Urgent incontinence, both men and women will experience that.
Mm-hmm. Yeah. I've had patients report that as we've tried to get them drinking more water in both areas.
It's, just to address that real quickly, it's amazing. I meet some patients and they come in, they're literally guzzling bottles and bottles of water. And I say, well, why are you drinking all this water? Well, I was told to drink all this water. It's good for me to drink all this water. And I still struggle to find data and studies that say it's, why do people drink all this water? I mean, I think there's a couple populations where it makes sense to really hydrate very, very commonly and a lot. And that's probably people who develop a lot of kidney stones. We want them hydrated a lot. Maybe a little bit in the recurrent urinary tract infection population. We can talk about recurrent UTIs because that's certainly something I see a lot as well. But on the whole kind of just drinking a whole bunch of water all the time is a little bit of an urban myth in what it can really offer people, I think. There is something to be said for drinking lots of water as part of dietary changes and maybe trying to lose weight, because the more you drink and the less you eat, the balance of calories is in your favor. You would know better than I would as a nutritionist. But on the whole, I think there's a little bit of an urban myth about water consumption. People sometimes just do it to do it, almost out of a nervous habit, that they feel like they have to be consuming something.
Yeah, and the more you drink, the more I feel like you need, right?
Exactly. The more you drink,
it's addictive, like anything, right?
It's a zero-sum game. Also, the more you drink, the more you're going to go, right? So if someone's drinking, 18 bottles of Crystal Geyser water a day, guess what? They're going to have urgency and frequency of urination. That's almost a given. So
yeah, and I'm curious: is there any irritation that drinking like a normal amount of water? Say someone drinks like 50 to 75 ounces per day, not an excessive amount, but is there any like irritation that could provide in any of these situations?
No, not really. No, water is nature's perfect beverage. There's really nothing at all concerning about drinking a lot, or except just realizing you're going to go to the bathroom a lot. I mean, that is the honest truth. I mean, the more you drink, the more you're going to go. But no, certainly from the water, there's nothing concerning at all about drinking water. Water is a great it's the best beverage to drink. I try to convince people to avoid the coffees and the teas and the chai lattes and the everything else. And some people just need their caffeine to be really happy in life, and I get it. That's a little bit of it's got an addictive quality to it. But I prefer beverages like LaCroix, bubbly, Perrier, flavored water. I think those are probably pelvic floor friendlier beverages than a lot of the other stuff people drink on a daily basis.
Sure. Yeah, definitely. Yeah. Well, I'd love to get into UTI, like you mentioned. Obviously, recurrent UTI is probably the most frustrating for people and happens both men and women. Tell us a little bit more about what is recurrent UTI. Why is this happening for people so often?
Yeah. And so when we have someone come in with recurrent urinary tract infections, generally we're expecting them likely to be experiencing more than 3 urinary tract infections over the course of 6 months or so. That would generally put someone in the category of recurrent urinary tract infections. And we like to get down to what are the bothersome symptoms someone may experience with a urinary tract infection. Could be burning with urination, could be malodorous urine, could be blood in the urine, and that's sometimes a little more worrisome. Sometimes people don't experience anything, and they just come in and they say, listen, my doctor has run these urine specimens and it shows bacteria and inflammation, and they don't really have any symptoms. So it's a very, very wide presentation and grab bag of people that come in with the moniker of recurrent urinary tract infections. And what I generally try to counsel people is, we want to engage a prophylaxis regimen. and that's multifaceted, to try to limit the experience of a urinary tract infection. We don't want them to be suffering with pain, discomfort. We don't want them to be on antibiotics all the time. And so there's a lot of different things we can try to enact on a day-to-day basis, some medicinal, some not, that may reduce and hopefully will reduce the burden of recurrent urinary tract infections. Now, I will say there is a cadre of people that are told they're having urinary tract infections, and they're probably not. A urinary tract infection, by definition, would really mean that you are experiencing some sort of infectious response to bacteria in your bladder or your urinary tract. So perhaps that's pain, perhaps that's an elevation of white count, perhaps that's a fever, one of those symptoms. Now, every now and then we meet people that come in and they've really got no symptoms whatsoever of urinary tract infections, but perhaps they do have a little bit of bacteria that grow in their urine, or perhaps they do have a little bit of inflammation in their urine on a voided urine specimen. And we have to be very diligent about trying to parse those people out. Generally, these are frail elderly people that are maybe living in assisted living environments, and they're on antibiotics all the time. And part of their challenge is they just pee into diapers and live in diapers all the time. And their urine is always going to look like it has an infection, right? They just literally sit in soiled cotton and pads and tissues. And if you take a urine or have a urine specimen submitted from one of these poor individuals, their urine will always have bacteria in it. And they really aren't experiencing fevers or chills or an elevated white count or something that might otherwise be concerning, yet well-meaning physicians and other care providers will give them lots of antibiotics. And we want to avoid that, because actually antibiotics in and of themselves have inherent challenges. One of those challenges is creating multi-drug resistant organisms. And so if you're on antibiotics all the time and don't have a really amazing reason for it, your body's going to build up resistance. And God forbid you're in a scary situation, you may not have a wide selection of antibiotics to choose from if and when you do have a real infection. The other things that can develop with a lot of overuse of antibiotics are Clostridium difficile infections. And Clostridium difficile infections is an example of an opportunistic infection, essentially an organism that overgrows usually in the colon in the setting of a lot of antibiotics where other bacteria are killed. And this organism kind of takes over, grows, and causes a super infection of the colon called Clostridium difficile, which may manifest itself as severe diarrhea, or perhaps even worse in some situations. And so we take pause when we're really trying to figure out who truly is experiencing recurrent urinary tract infections. And once we know who those people are, and at face value, it's probably going to be most people walking in the door, we try to get them on a prophylaxis regimen to reduce the occurrence of urinary tract infections.
And can you tell us a little bit about what that looks like, that prophylactic regimen, or what are some things people can do to prevent a future UTI if they're prone to recurrent UTIs?
Absolutely. So, let's take an index patient. Let's say 55-year-old woman comes in experiencing, urinary tract infection. She's had 3 to 5 of them over the last 6 months. She experiences burning with urination, malodorous urine. She's seen blood in her urine a couple of times with the urinary tract infections, and the urine specimens have grown bacteria, and her symptoms get better on antibiotics. What we offer this sort of patient? Well, initially, let's talk about the regimen. And I give a big sheet with this all listed on there because it's a lot of stuff, right? but some of the core things we talk about, there is a prescription medication called methenamine. So what is methenamine? Methenamine is I describe it as an antiseptic. It's really not an antibiotic. And what that particular medication does is it changes the pH of the urine. So the bacteria don't like living in the urine as much. And so it actually changes the quality of the urine. So there would be less bacteria that would find a home in your urine. And you take it twice a day, in the morning and the evening. And it will be a chronic or long-term medication. And I always tell patients at some point we can stop it and see how you're doing, but we want to try to break the cycle of recurrent UTIs. The thing to remember with methenamine is, number one, you've got to have good kidney function. So we can't give it to patients with renal insufficiency. And number two, you have to stop it if you're ever prescribed antibiotics. So if a dentist prescribes you an antibiotics for a tooth abscess, you've got to stop your methenamine and then restart it after you finish the antibiotics, because methenamine doesn't play nicely with antibiotics and they're not meant to be taken together. One of the other things we talk about are some more holistic products. There's a particular company I like called Solve Wellness, SOLV Wellness, based in Atlanta, Georgia, and I've interacted with them over the years. They make several high quality, non-prescription based products that I think my patients have done very well with in goals of preventing and reducing the occurrence of urinary tract infections. One of those products is a cranberry product called Illura. Illura is I think the top of the line of cranberry products for UTI prevention. I mean, I think if you walk into Walgreens or CVS or Costco, there's a myriad of different cranberry products out there. I really think the Allura product is, in my opinion, the best one. It is more expensive, and that we always go over that with patients, but I think it offers something called 36 milligrams of proanthocyanidins packs. Proanthocyanidins. Now, what is that? That is the magical component that lives in cranberry that we think probably helps reduce the risk of urinary tract infections. The cranberry juice doesn't work, doesn't help. I have some patients, I drink cranberry juice all the time. If you enjoy it, please drink. It does nothing for UTI prevention. It may just add some calories to your diet. And so I think Allura is a great product. The other product the company makes that I think is an interesting product is a probiotic called Mage. Now, probiotics, listen, it's hard to find amazing data to say probiotics make a difference. Theoretically, it's a great idea, giving your body good bacteria in the goal of trying to limit out the challenges that someone may be suffering if they've been on a lot of antibiotics and have challenged some of their microbiome. Microbiome is a kind of a catchphrase for the bacteria that live in your body. And so I generally will have patients consider taking probiotics. I think adding some additional good bacteria to the microbiome is not a bad thing for someone suffering with recurrent urinary tract infections. And then the other thing they make is a vaginal moisturizer. The vaginal moisturizer doesn't have any hormones in it. It's delicate. It's meant to really hydrate the vaginal tissues. I think that or estrogen cream is a very reasonable approach. So estrogen cream is something that can be applied topically to the vaginal tissues for women who are experiencing vaginal atrophy. Generally, these are peri or postmenopausal women. And it's a cream that's applied topically up to 3 times a week. And the goal of the estrogen cream is to hydrate and thicken the vaginal wall tissues. And we know that we have data to support that thickened, hydrated vaginal wall tissues are less likely to be in an environment for recurrent UTI bacteria to find a home. And so whether it's the vaginal moisturizer or the estrogen cream, we also talk about some sort of topical cream application to the vaginal tissues on a fairly regular basis, whether it's daily, every other day, throughout the week as well. Should I keep going?
Fascinating. You didn't mention D-mannose. Is that one that you recommend? Yeah,
D-mannose is definitely on the list. D-mannose certainly is something people can take. I have it on the literature I give patients. I think, a little equivocal on how much it does or doesn't do, but absolutely, why not? I think it's something to consider and do. It attaches to the feet of bacteria. Hypothetically, it helps wash those bacteria out of your urinary tract. I think certainly very reasonable to consider utilizing D-mannose as well.
Enjoy high-quality supplements shipped right to your door with full script through Private Physicians Medical Associates, PPMA. Reap the health benefits of pharmaceutical-grade vitamins while saving 5% on all orders. Set up your free PPMA account today. Visit privatemds.com.
And then is there anything within that, the recommendations that are like avoidance type things in terms of, I was once told by a doctor, I like to sauna, for example. And they said, make sure you're not wearing underwear when you sauna, right? Something like that could be problematic. But for example, is there anything like that, avoidance type things that you find to be really helpful?
I wouldn't say avoidance, really. I mean, there are some other behavioral patterns we'll discuss, and one of the phrases we use and talk about is perineal hygiene. And so what is perineal hygiene? Perineal hygiene is really trying to cleanse the bicycle seat area, the skin between the rectum and the vagina for women suffering with UTIs. And, generally it's more of a challenge for our frail elderly patients, not really as much a challenge for our younger patients.
But, if you're a fairly elderly person, that's kind of a hard area to clean at times. Very commonly, actually, especially if you have limited mobility and poor dexterity. And if you're in diapers for urinary incontinence, you can only imagine, right? So when we talk about perineal hygiene, one of the things that I'll ask patients to consider doing is purchasing a toilet top bidet. And you can get those for about $75 now. And you attach them to your toilet seat. And, a bidet is a bidet. I'm not sure how familiar the audience is with a bidet. Some people know what it is. Some people have no idea what it is. But essentially, it helps cleanse the perineal and rectal area after bowel movements and toileting. And what I'll encourage patients to consider is, after toileting, perhaps consider using a toilet top bidet to help cleanse the perineal area, which is the skin between the rectum and the vagina, to reduce likelihood of fecal soiling and other bacteria living on that skin that could cause urinary tract infections. Because that's really the highway for UTIs, right? That's the route from the fecal reservoir going towards the urethra. And, in a woman, the urethra is only 4 to 5 centimeters. And so that's not a short distance for bacteria to travel to start causing some challenges in the lower urinary tract. And so I think a toilet top bidet is not a bad idea. If a toilet top bidet, which you can find online in many places now for $70, $75, is not possible, you can always just get a spray bottle from Target, put some water in it, put some Dove soap in it, and keep that next to your toilet seat and kind of spray that perineal area down after toileting as well. And that may help too. I know some people use some of the cleanser wipes that are out there. Those are okay. Those aren't bad. You can use those. It's probably better than nothing. I think as far as bowel movements we talk about. So if someone suffers with severe constipation or loose bowel movements, that's also risk factors for UTIs. And I would generally say try to avoid that. Really what we want someone to be having one soft form bowel movement a day. We want someone to be having a regular, easy bowel movement, kind of like you're being a 747. We want you to land on the toilet seat, be there for a couple of minutes, pretty easy, have a soft form bowel movement, and then take right off like a 747 and you're back up and you're doing your business. And so if you're struggling on a toilet for like 20 to 30 minutes to have a bowel movement, or if you're having loose bowel movements all the time and doing a whole bunch of cleanup, those are also kind of setups for suffering with recurrent urinary tract infections. So it is kind of important to think about your bowel movements as well in the world of urinary tract infections. And then, the other thing I talk about patients with is urine specimen collection. I can't tell you how many patients I've seen them in my time that go to these urgent cares on the weekends or during the week, and they do their voided specimen, their clean catch specimen, and they get this printout that says, you have a UTI. Clean catches are very hard to do, meaning you're going to try to catch a midstream urine collection in a cup. Once again, probably easier for younger patients. 75, 80, 85-year-old person's going to be able to do that? Well, no, probably not. And so I actually, would say, and there's reasonable data to support, up to 20 to 30% of these clean catch urine specimens are contaminated. And they're probably just culturing the skin of the labia or the vaginal tissues or the pelvic floor area. And so when a patient is experiencing UTI, what I generally will ask them to do is to call our office. It's Monday through Friday. Generally, they can reach someone that same day, come in to see myself or one of our physician assistants or registered nurses. And we like to try and do catheterized urine specimens. For women particularly, where we take a small catheter, 12 French, pass it into the urethra, takes about 30 seconds to do, and drain the bladder and send that urine specimen out. The catheterized urine specimen is going to be much more reliable data, much less likely to be susceptible to contamination. And so that is something we try to do when we can. It's not always possible. But that's better data if we can get it to kind of determine what a pattern of recurrent UTIs looks like.
Sure. Wow. Okay. That's really good to know. And I would love for you to just talk, we talked a little bit about the overactive bladder and some of the components that go into that and hydration pieces, of course. But could you tell us any other types of recommendations that you might have for how to prevent, having to use the restroom every 5 minutes for someone that's dealing with overactive bladder, or what that treatment might look like?
Yeah, when we talk about some behavioral modifications for lessening of urgency and frequency, some of that we briefly touched on. Coffees and teas, probably not your friend. And so try to drink less of the Starbucks coffee bean tea leaf, more water, less products with even teas, even herbal teas are diuretics. Alcohols are diuretic. So these are all things in the sense, meaning they just run right through your system. I mean, you're going to be going to the bathroom pretty commonly. So be cognizant of what you're putting into your body. The other thing we talked about for people that may be suffering with urgency incontinence and stress incontinence, try to put your bladder on a schedule. Challenge yourself a little bit. If you have an Apple Watch or iPhone or a smart wearable, you can set it to go off every 2.5 to 2 hours, and try to go to the bathroom on a schedule as opposed to letting your bladder dictate when you go. Maybe that goes well, maybe it doesn't. It's going to be informative either way. Maybe it lessens the burden of what you're experiencing. Maybe it doesn't. But once again, I think trying to challenge your bladder to be on a schedule as opposed to letting it tell you when to go is an educational endeavor all into its own. And sometimes, actually a lot of the time, people see benefit with that. The other thing I would suggest, and these are for people that suffer with waking up a lot of night to go to the bathroom, is not to drink fluids for 2 to 3 hours before you go to bed. Avoid the nightcap, avoid the beverage consumption after dinner. Once again, be cognizant of what you're putting into your body. There is also pelvic floor physical therapy. So pelvic floor physical therapy is working with someone one-on-one to really engage in yoga and yoga-like exercises and biofeedback-like education to control the pelvic floor muscles and ligaments. And everybody thinks it's just Kegels. That's just the tip of the iceberg. Really, if you work with someone who's knowledgeable, it's much more than Kegels. And the trick is to find knowledgeable people and work with them one-on-one if possible, because that's really where you make a lot of headway and gain a lot of knowledge. Now, how much you get out of pelvic floor PT is how much you put into it. And it's not going to be every patient that sees a whole bunch of improvement or a whole bunch of wins as a result of it. But generally, it doesn't hurt. There's no risk. And the only real investment is time. And so pretty low threshold to ask someone to consider pelvic floor physical therapy.
Yeah, wonderful.
Go ahead.
And you started to talk about pelvic floor piece, and I wanted to definitely talk about that at some point too. And so before we wrap up, maybe you could just tell us a little bit more about, just give us a little bit of like an overview of what you typically see in your office and kind of what that process looks like because obviously you're probably trying to prevent surgery as much as possible, but at what point is surgery probably something that's required and necessary for someone?
Yeah, it's a real good question. Surgery almost is never necessary in these quality of life challenges. Very, very rarely. Some unusual circumstances. Certainly, someone may be at their wit's end and really not be able to function and be the human being they want to be as a result of these processes. But generally, they're not life-threatening processes. And so the ultimate decision to move on to a surgical intervention is rarely a need to. I really try to arm patients with knowledge. Give them a buffet of options, let them know what they can do. And a number of them do choose surgery, and surgery has its benefits. The benefit of the surgery is it can be definitive. You can walk away and perhaps not suffer nearly as much with what you're experiencing. It probably is not as painful and longer recovery as you might think it is. It can almost, it can change someone's confidence and almost make them a new person in some instances. Now, that means that surgery has risks: infection, bleeding, damage to organs and tissues. Perhaps you have to be away from work for some time. So there's always a plus minus. But there's almost never a must to do surgery. We have a lot of ways to do surgery for stress incontinence, for urgency incontinence, for things we haven't talked about like pelvic organ prolapse. There's a lot of different ways to do operations to try to improve someone's quality of life. But thankfully, it's almost never a have to. Some circumstances exist, but they're not too common.
Mm-hmm. Okay. So what would you say with most of the patients that you see, are they able to really see improvement through some of the kind of first line of defense type recommendations that you have?
It's a pretty wide presentation. I will tell you personally, I really like patients to walk through conservative measures first. And we have a pretty thorough discussion about that. I would say 50-50. Certainly a number of people will see improvement with just conservative therapies. And then there are certainly a subset that go on to surgical interventions to really get the quality of life improvement they're seeking.
Mm-hmm. Sure. Okay. Awesome. What did we miss in terms of your bread and butter of what you do every day that you would love to tell our listeners about?
Well, I think we've covered a pretty. We could talk for hours. But there's so much more stuff. But I'm also cognizant of when I listen to podcasts. Like if drones on for too long, you're like, okay, I'm kind of done. But I guess I would say this also. if you notice something changing in and so my brother is a gynecologic oncologist, and so he works at City of Hope Orange County as well. His name's Josh Cohen. And so what's really wonderful about our setup is him and I have a pretty close collaborative relationship. So we can care for some pretty complex patients pretty fluidly, which is really nice. And what I've learned from caring for patients that have seen him, and even my own patients over the years, is that be in tune with your body. If you're having more abdominal pain or bloating or more sense that you're running to the bathroom a lot more often than you did even in just a couple of months ago or a month ago, don't ignore these things. Generally try to seek out medical evaluation, because hopefully it's something relatively minor, but every now and then there's something scary lurking, like God forbid an ovarian mass or pelvic floor tumor or a uterine mass that may be cancer. And these are things that we don't want to miss. We don't want to miss. And so I don't say this to scare people, but I do say, please be in tune with your body and understand what's going on. And if you notice something changing, some symptoms that are different, it's okay to ask for a medical evaluation. It's okay to ask your primary care doctor to do an ultrasound or an exam or to be referred to a urologist or your gynecologic oncologist or wherever else you can get the evaluation that you need. I think it's important to keep that in mind, is that sometimes we'll just say, it's nothing. It's whatever. I'm busy. I've got to go to work today. Don't forget to take care of yourself. Don't forget to listen to what your body's telling you and have that evaluated.
Good. Your body's, you only get one body, right? So you got to take care of it.
That's right.
Well, thank you so much for your time. And for any listeners that are listening that would love to get a referral, contact our office, and we'd be happy to be able to provide you with Dr. Cohen's information so that you can get a referral over there. And I would just love if you would tell our listeners too where your office is located and just a little bit more about how to kind of find you too.
Yeah, no, absolutely. It's first of all, and once again, an honor to be here with you, Lauren, and PPMA. It's, what an esteemed group, and just a pleasure to be a part of this podcast. I would say that you can find us online. So if you look up City of Hope Orange County and you look for Seth Cohen, SETHCOHEN, or Josh Cohen, as I alluded to, my brother, and we're on there, and we have a pretty robust women's health program, particularly at City of Hope Orange County, but a lot of great care in other avenues as well. We have our main center in Irvine, near the Great Park area. It's 1005 Point is the address in Irvine. You can see the spectrum from where we are as well. Right now, there's a crane next to our building. If you see a crane going down the 405, that's the new hospital that's going up. It's going to be 6 stories tall. That'll be built for City of Hope Orange County by the end of 2025, so a couple of years away. I also see patients at our Newport Beach Fashion Island office. So we have City of Hope Newport Beach Fashion Island, which is exactly where it sounds. It's right across from Fashion Island. And then Josh sees patients over at City of Hope Huntington Beach. Actually, we also have a Huntington Beach office too. And so between Irvine, Newport Beach, Huntington Beach, we've got several different locations in Orange County that we can certainly try to provide access to care. Our number is 949-671-4673, 949-671-4673. And so that's a phone number you can call our facility at. But certainly online is a great way to start, and then reaching out. But we're here to help. Very happy to be as I said, I grew up in Orange County. It's my home base. So extremely happy to be back in the area and trying to make a difference for people.
Yeah. Well, thank you all for all you do for patients, and really grateful for your time and your expertise and knowledge today as well.
Thank you very much.
Thank you for joining us for today's episode of Nourish MD, Doctor Dietitian Dialogues. This podcast is intended for general educational purposes only. It is not a substitute for professional medical advice. Please consult with your healthcare provider before beginning any nutrition or supplement recommendations. Sign up for our mailing list so you'll never miss an episode of our wellness journey. See the podcast description for the link.